recording, and let's start with orthopedics. So good afternoon. I am still Major Chalupa. We still met last week, and we are going to start our formal lectures in orthopedics today. So our first lecture today is going to be on systemic pathology. So kind of the way I set this up is I'm going to do an introduction right now and go over some things that you're going to need to know kind of for the entire course, and it'll help differentiate when treatments come up and some things like that. And then after that, I'm going to launch into some of the pathologies. And then as soon as we get done with the lecture, then the quiz is open and you guys can transition over to taking the quiz. If you would like to do it now, it will stay open until just before we start lecture tomorrow. So let's go ahead and launch into some orthopedic principles. So the first couple things I need to talk about are kind of the differences between treatment modalities. So that's what these next couple sets are out. So I don't have to talk about these every single time we talk about a pathology. So they should look pretty familiar in terms of that. You're going to need to come back to these first couple slides if you're unfamiliar with some of these concepts later on when we talk about fractures and things like that. So first things first, let's talk about non-steroidal anti-inflammatories versus corticosteroids. So with those non-steroidal anti-inflammatories, so if you'll remember from pharm, I think this is the block you're in right now for pharm, or took your test on today, isn't it? Pain medicines, right? So yeah, let's celebrate your accomplishments this morning, and we'll build on that. So non-steroidal anti-inflammatories, they come in two general forms. So they can come in I suppose you can inject some too. So 3. With ortho, I don't inject a whole lot. However, I use a lot of oral and topical anti-inflammatories. Now, the oral anti-inflammatories, those come with some side effects, and the big ones for the purposes of this course are going to be those gastrointestinal ones, and then the cardiac adverse effects. So with especially the gastric side effects, those can be nearly eliminated to the point of I can't control it any longer with topicals. So my personal indication for switching from an oral to a topical anti-inflammatory is that. So like a gastroesophageal reflux disorder, something else going on with their stomach that I should bypass that route. And then I always take just a quick note of any cardiac problems they have, lest I give them something and muck with their heart, because I don't do squishy bits. That's what Colonel Jones is for. So those are my two big notes for non-steroidal anti-inflammatories. A second treatment modality that we're going to see a lot when we talk about orthopedics are corticosteroids. Now, specifically for this, corticosteroids for me are injectable. So I've kind of given some indications here about some of the big risk factors that come with injectable corticosteroids. So the first is this one here. And this is someone injected something in this general area of the poor person's arm. And the steroid can reduce the fat underneath that in that subcutaneous layer or bleach the skin. So those are two of our risks with corticosteroids. I have no idea why they were giving a steroid in this area, but I did like that it had both the fat atrophy and the bleaching of the skin. Another type of adverse effect of that, specifically corticosteroids, is tendon rupture. So when we talk about pathologies later, like the rheumatoid arthritis, where we can use corticosteroids to manage that inflammatory process, we just need to be careful because they're already at risk for tendon rupture. So that's kind of another set of things that I try and watch. My last note on corticosteroids and some of the risks and concerns are a theoretical risk of cartilage damage. So this is a picture of an arthroscopy, so a scope within a joint, and it's showing some cartilage damage. The nice white surface is the cartilage, and this is like a hole in that cartilage showing us the underlying bone. And I say theoretically because we have seen this in experimental animals, but we have yet to prove it in humans, mostly because we don't want to damage their cartilage. So if you have when you are considering joint injection in a patient, you need to be aware that we generally set a 3 steroid injection max at any joint. And in ortho, we will violate that pretty regularly, but as primary care, I want you to kind of set that as a personal standard. In terms of the text defining that, it really doesn't in this general section, but it will when we get to shoulder. But it's not something unique to shoulder, so I just wanted to bring that up now. Yes, so a lifetime limit, the life of the joint. The reason I don't say it quite like that is because I can throw a couple more in after we replace the joint. Okay, so those are my big comparisons for kind of 2 of the inflammatory modulation methods that we use for pain management in orthopedics. Our next kind of treatment differentiator is going to be the difference between a splint and a cast. So this goes on to talk about there are even more things than just a splint or a cast, but I really put these 2 in because this may not be something that you're familiar with. So the key difference between an orthopedic splint and a cast is that the splint does not go all the way around or is not circumferential. So here on this image on the left-hand side, we have an ulnar gutter splint. And this off-white yellowish material, that's the fiberglass material, probably an ortho glass if you're familiar with that. And it's molded and shaped into the shape that we want the splint to be. So it is not circumferential. Whereas with a cast, it is complete, it goes all the way around the appendage. So it's circumferential. That being the big difference between a splint and a cast. So why would I not have something go circumferential? It has to do with swelling. So if I expect an injury to continue to swell, then I'll put them in a splint so that it's not creating an artificial compartment syndrome or created by me. But if I'm know that this is a joint that is probably going to swell less, that it's a pretty stable fracture, then I may put them in something that goes all the way around for a longer period of time. Purple fingers are bad. Yes, Anders. Okay, so the difference between a splint and a cast. There are other words. So a brace may be one that we come into later in the course. That is usually something that I consider an off-the-shelf thing that is removable. Even this splint is not meant to be taken off. It is something that I am putting that patient in so that I know that they're being treated until they see the surgeon or they come back for their other cast. Whereas a brace, something that they can take off and wash their hand and come back. Yes, so I support that way of thinking about it, Harris. So a splint would be something that we would want shorter term, whereas a cast would be a longer term treatment. Baxter, Orthoglass is like it's like the term Kleenex. So it's a specific brand, and we can do whatever I want with it. So the difference with Orthoglass, which is kind of why this is a weird picture, is Orthoglass has a whole bunch of fiberglass here in the middle and then padding all the way around the outside. There's usually a seam out here. I can use it for whatever I want to, but I tend to use it more for splints than I do for casts. Casts, I'll use a free fiberglass roll, whereas a for a splint, I could use a plaster or an orthoglass. Orthoglass is available in the Army sets, kits, and outfits. Plaster is usually reserved for higher echelons of care. So Anders, casts shouldn't get wet because it traps the moisture and there's no way really to dry them out. So kind of in this middle section where the airflow is not great, it would basically rot, and it creates ulcers that smell really bad and are really gross. When I think about those things, I think of actual smelly ulcers from undercasts. Smell memory. Okay, our next topic is we're going to talk about the difference between open and closed fixation. So in orthopedics, we can do two methods of getting things to straighten out. Closed reduction, so usually referred to as closed reduction with percutaneous pinning, or CRPP. Let me write that down, just because that may be something you see when going over somebody's notes. So closed reduction, percutaneous pinning means that we use these things that are like very thick paper clips. And they have very sharp ends on them, as you can kind of see from these fluoroscopic images. And we drill those straight into the bone to get it to, so we can manipulate it. We toggle it very much like a joystick. And we would make that bone straight through those methods. The biggest the hole gets is just a tiny thing for us to see. It's less than a centimeter for us to see where we're headed with that pin. So it's not a big hole. We use closed reduction and percutaneous pinning mostly on pediatric cases. There are a couple things with adults, mostly in the hands, that will use closed reduction and percutaneous pinning, but that's about it. So pediatric and hand, really the only times we'll use that adult hand. Pediatrics, adult hand. Our second option is probably what you're more familiar with in terms of your general experience with orthopedics, and that's open reduction with internal fixation, or ORIF. So with the open, that means all the way open. So these big giant holes, incisions that are several centimeters long. We have localized that fracture here in the middle of the image. And then we put on these big plates, and they're held in place with plates and screws. Screwdrivers, just like the ones you use from the Home Depot, except they can go through a sterilizer. Okay, so this is mostly an adult treatment, though we do have some pediatric variations that we will use as well. Intramedullary rods could be considered this as well. Probably not, Jacobs. Probably not as cost effective because they have to be sterilized. Open reduction, internal fixation. Specific cases. Long bone fractures, so like the femur or the tibia would be kind of the first one that comes to mind. And Morgan, hands for CRPP in adults. No, you just wanted the opposites. I'll go with those lower extremity long bones. And now I'm going to do a kind of twist on that. So here's those images of the long bones with the intramedullary fixation, just for your imaging. So that's that forearm open reduction internal fixation here in the bottom left. These ones in the upper center are intramedullary rods. IM is how we abbreviate it, IM rods. So they go down the medullary canal and are held in place at the ends by just a couple screws that we can get in percutaneously, so through those little tiny holes. So big hole to get the rod in, but little holes to get the screws in. So we use those in the long bones, most commonly of the lower extremities, so tibia and femur. And then we have some screw fixation that is also internal. So this is a femoral neck fracture of some make and model that they have put these 3 screws in to hold that in place. So these are all internal mechanisms of fixation. So they go with that open reduction internal fixation term. But we do have something more temporary that you may see when you're deployed that's external fixation. So external is outside the body, looks a lot like an erector set, but we drill these pins very similar to those that are in the percutaneous pinning, but these are a lot thicker. And we'll drill these in, and we can do this in like a trauma bay. So it's not, doesn't have to be in the OR. This lower left image is done in the OR because they're putting in this circumferential set. But we can do these in the ED all the time. And we put these in if the wound is contaminated or has some reason that we can't go in and do the internal procedure because of the risk of infection. So that's why we tend to use it a lot downrange, is because we get a lot of contaminated wounds from shrapnel or dirt or the environment they rotted in until we could get them and pick them up and take them to the hospital. So that may be something you see in some scenario where we do the external fixation. And so that's an external fixation device or external fixator. And they go on any part of the body. So Jacobs, we actually like those souvenirs. Those souvenirs are badges of courage or something. That is a lesser consideration in terms of external fixation. External fixation is generally a staying procedure until they can get to the internal fixation method. Yes, thank you, gentlemen. Okay, so those are some general concepts that we're going to need to put into play in a couple of the different pathologies that would talk. They'll be less useful for today's lecture, but you'll begin to see some of those come into play when we start talking tomorrow. So today, for the remainder of this lecture, I'd like to talk about 6 general principles. So we're going to talk about amputations of the lower extremity, osteoarthritis, rheumatoid arthritis, the seronegative spondyloarthropathies, compartment syndrome, and complex regional pain syndrome. Especially with these 3 arthropathies, these are going to be building blocks that we'll need for other conversations that we have down the line. So you'll see that they're very general and they cover a lot of things, a lot of different body parts. But these are the systemic guides to the more specific joints that we'll apply them to later. So let's go ahead and start with the amputations of the lower extremity. In terms of things that I need you guys to know for these, I need you to be familiar with the levels, which are on the next slide, and then kind of some things that the primary care should treat, and then when they need to be referred. So let's go ahead and talk about why. Why would we amputate? So in parts of the world where they don't wear this outfit all the time, amputations are actually caused by systemic disease, 70% of them. So that systemic disease could be part of diabetes. It could be an infection to the lower extremity or peripheral vascular disease. Pardon me. Must be Monday. Talking's hard. Okay, so systemic disease. And with this, some adverse outcomes could be a limb ulcer or infection. So if we were amputating for infection and we didn't get it all, didn't eradicate that area, there could be some residual infection. Some skin conditions kind of coming back to things that are trapped in hot, sweaty areas that could come into play underneath a prosthetic, and then amputation-related sensation. So all three of these are adverse outcomes that can be treated by primary care. Yes, you might not feel comfortable right now, but it will become something that you guys are capable of treating. So in terms of residual limb and ulcers and infection, so infection's a big problem, depending on if it's like a cellulitis or superficial infection versus a deep infection. So kind of as I introduced this topic, I alluded to infection being a cause. So if it's suspected to be a deep infection, causing more systemic effects, then that would need to be elevated to an advanced level of care. Whereas a superficial infection like a cellulitis, that can be treated by primary care. Same with a superficial ulcer, especially one created by their prosthetic. So if they have limb ulcers or infections that are related to their prosthetic wear, a period of not wearing their prosthetic may be enough to help them if you would treat them just as any other person with a cellulitis or an ulcer. Let me pause and look at Scott's comment. It's of the amputation, Scott. Though I suppose it could be both. Mostly I'm considering it of the amputations. Skin conditions. So with this, I'm talking about systemic skin conditions like psoriasis. So psoriasis can occur underneath a prosthetic, which would be very troublesome for that amputee. That skin condition should still be treated like psoriasis would be treated in another patient. Again, may have to do with a period of leaving their prosthetic off, but other treatments, systemic treatments, would still apply. And no, I'm going to ask Diana, do I say Mendoza or do I say Desenez? It's great. Senez. Yeah, emphasis. Okay. Just making sure. Like science. Okay, I'll take that. And no, not to a dermatologist, to an orthopedist. Me. Special. Okay, skin conditions like psoriasis, we talked about. Okay, and then amputation-related sensation. So you may have heard of this as like phantom limb. So they have sensation distal to their amputation part, or pain is usually the sensation that they have, unfortunately, distal to that amputation point. And those we treat with sympatholytic drugs like gabapentin or pregabalin that stop that signal from coming back and being interpreted by the brain as a problematic signal. Thank you, problematic signal. So all of those can be treated by primary care. Anything above and beyond may need referral. And we'll talk more about it kind of going into the who gets what here in a moment. I have this all on smashed on one side because this is about how much I need you to know. And so I'm just going to talk through each of these levels. And then if you guys have any questions about them, please feel free to ask. But I mostly just need you to kind of associate a level with where it is on the body, which is all in the name. So first one, toe amputation. So a toe amputation is exactly what it sounds like, a toe amputation. So some reasons that we would do that, if it were crushed beyond repair, that would make sense. Occasionally, an infection like osteomyelitis or a bone infection may be a good reason to do a toe amputation. Now, toe amputations in anything other than 1 and 5 are really weird because the rest of the toes like fold in around that space where the toe used to keep things kind of split down. So they kind of, oh, hold on, got to aim for the camera. So they'll smash in, which may cause the patient some discomfort. So we may not use a toe amputation on the middle digits. So what would we do? A ray resection. So in this, the metatarsals with the distal phalangia are considered a ray, like from the sunshine. And if my hand were the equivalent here, we would say that this ray, we would take that entire ray out. So we would take out the metatarsal, even though I'm pointing to a metacarpal, all the way out to the end. And then there wouldn't be that same folding in of around that missing toe. And then you also don't notice that they're missing unless you sit there and count, which is it. Most people skip that part. So I can use a toe amputation on 1 or 5 and raise through 2 or 4. I accept that, Rodin. Okay, a midfoot amputation is going to be anything through the midfoot. So mostly through the metatarsals, but also could be at the tarsal metatarsal joint. And that could be used mostly for an osteomyelitis that's affecting a metatarsal, because that happens pretty quickly in a diabetic foot. So we would just go ahead and everything that was safe, we would keep that, and everything distal would go. That's a great question, Jacobs. Probably not. I think that you would say that it's missing. But you would have to use a whole lot more words to be clear, which is sad because we numbered them for a reason. Okay, midfoot amputation, metatarsal phalangeal joint, or somewhere in the mid-metatarsals. Hindfoot amputation is usually between the joint that makes up the talus and the calcaneus, so they're stacked on top of each other, everything distal to that. So it'd be like a mid-tarsal amputation. There are some weird versions too where you get to keep the talus and lose the calcaneus, but it's anything that's within the tarsals, I guess, is a fairly good rule of thumb for what hindfoot amputation is. Now, the disarticulations mean that it goes through the joint. So anytime we have disarticulation here in these 3, that means that they keep the normal weight-bearing end of the joint, and they just make it so that's where they end. So straight through the ankle joint, they file off the ends of the malleoli so that they are not standing on those malleoli all the time. And they basically, the tibial plafond, we'll learn that term when we get to foot, is where they bear their weight. So disarticulation means to take apart at the joint. Below knee amputation, exactly what it sounds. Somewhere between below the knee in the diaphysis of the tibia is where this will occur. We get to do some cool things to fix the fibula in, otherwise it wanders off laterally and does its own thing because it's not tacked down. So there's some variations on below knee amputations and how they manage the fibula that are the generation of how they're surgically different. That's just nice to know stuff. In terms of levels or how long the limb is, that is predefined by biomechanics. And so we know the most biologically advantageous length for that limb to be. So it takes into account kind of where the hinges are for any kind of prosthetic and how much energy it takes to extend that limb once it has a prosthetic on. So we have that down to a pretty fine science now. This one's more common in our population just because of how we earn our amputations. The knee disarticulation is our next level. So again, similar to the ankle, that means straight through the knee so that the weight-bearing ends of the femur are the ends that they bear weight through. Sorry, that was my cell phone going off and it's Colonel Jones. It's great. Boss is calling and I'm sitting here teaching. Okay, disarticulation through the knee, the ends of the femur are then what bears weight in that. Let's see here. Andrews is asking, weird tendons to help with the pain? Not necessarily, but yes, Law, I believe that. Why is the boss calling during lecture? Okay. Mostly you just need to know the levels, Andrew, so that you can speak articulately about these levels when you are typing up your notes. Thanks. I appreciate your support, guys. Okay, above knee amputation. Very similar to the below knee amputation, there is an advantageous level where we biomechanically know where the prosthesis should go. Has to do with that knee articulation joint and where that can be so that they can actually use their knee to sit and stand and walk. So we have that one down pretty well as well. And in terms of picking one between like a below knee amputation and an above knee amputation, that's all about, we want them to be as long as possible because the longer the limb, the less energy it takes to move the limb, like to walk. So to fling out less of a prosthetic takes less energy than a longer prosthetic with a mechanical knee. So we try to keep them as long as possible, So it was redundant, but not. The last one on here is a hip disarticulation, and that's just as it sounds. So we take that femoral head out of the acetabulum, and that is where we end the limb. There are some extra special ones that go beyond the scope of this course, but we do have some weird ones that we can do with half pelvi, where we take half of the pelvis, and they're very weird. So super fun. Charter, I feel okay with that. So there are a couple places, maybe in the midfoot, where that might be more advantageous in terms of trying to figure it out. But because they're related to systemic diseases, these are usually sequential things. So we will be taking off more eventually. So we do kind of play in some biomechanics, like which prosthetic is going to be better, but we don't want to shorten them prematurely because then they're not going to have a lot of limb left. Jacob's rotational plasties usually have some degree of, we cut the bone somewhere in the middle and we'll twist it axially. Fun word to listen to Major Chalupa say, axially. So that may have been some other procedure, but if you want to talk to me about it during break, we can see if we can figure it out and then we can tell the class about it. And yes, that's exactly right, Morgan. So once we reach, if we are so short that we're not going to be able to be biomechanically advantageous, then we may consider going above that to add to the biomechanics. Prosthetics fits and that kind of thing. Okay, some principles with prosthetics fitting, and if I have to come back, somebody's typing right now, but I'll come back if I have to. So kind of with those disarticulations, those ends of the bones are meant to bear weight. So they accommodate weight bearing pretty easily. So for instance, a patient can walk around on their knees. I just used air quotes. I turned into one of my children. They may be able to walk around on their knees pretty well because the end of the femur is designed to bear weight. But once we go cutting anywhere in a mid-diaphyseal region, the bone is not designed to bear weight through that. So we have prosthetics that are designed to kind of distribute that weight. So it's actually not just the end that is bearing the weight, it's actually kind of suction cupped on to the distal limb, and that helps distribute the weight to the sides as well as to the end. So that's a little kind of weird for like a first pass, but once you get kind of, oh, that makes sense because there's nothing padding down distally, you kind of just once over and you're like, oh yeah, that totally makes sense. Let me read Parks's question now. Yes, Parks, those are both correct. So a midfoot would be either in the metatarsal, within the metatarsals, or a tarsal metatarsal joint, and then a hindfoot, anything within the tarsals. Those are correct. And then the cool thing about prosthetics, especially within the military, is that most patients have as many prosthetics as they have pairs of shoes. So like you have a pair of, hopefully a pair of running shoes, a pair of boots that go for your military travels. This guy over here, he has a swimming prosthetic. These are what most running prosthetics look like, but they're like shoes. You need to have the appropriate tool to do the job. And every patient will go through a bunch of them as the muscles around the end of their residual limb start to atrophy because they're no longer pulling on anything. So they don't have that same demand for large muscle mass. So they'll atrophy down to kind of be skinny, sad chicken limbs. And that will change that suction cup aspect of the prosthetic. So we'll have to give them a new prosthetic to help with that. And it's possible, Roden, I'm not going to make any comments on pretty shoes. We'll save that for block 4 because we talk a lot about pretty shoes in block 4. Okay, so your referral decisions and red flags for this. Minor things still need to be treated by the primary care manager, so that may be you. But the more significant things, deeper prosthetics, those need to go to an appropriate referral person. So not all of them are ortho, but they're usually in the ortho department. So if it's something to do with their prosthetic, like an abnormal wear or something wrong with their prosthetic fit that's causing a problem, the patient can usually tell you which it is. Those need to go to a prosthetist. So that is a different consult than to ortho. If it's something like a deep infection, that definitely needs to come to ortho so that we can judge whether we need to keep taking off part of that limb. Dermatology, so we talked about dermatology. Maybe if it's like that psoriasis case I brought up earlier, maybe that patient needs to go to dermatology. I think those wound care is really the only other one. So some of the superficial ulcers could go to wound care as a separate consult service. Jacobs, they might have date night shoes. I'm not sure, but it sounds like something that would totally be a prosthetist. Yeah, I'm gonna stop trying to say that word. I'm gonna go with yes. Pretty shoes, so pretty. Okay, let's move on to a topic that we're going to see a lot of in both our patient populations and in our studies of orthopedics, and we're going to talk about osteoarthritis. And I probably will get through all of these slides and then we'll take the break. So osteoarthritis, bone-based arthritis, is the general aging process of the joint. So each joint end is covered by cartilage, and all osteoarthritis is kind of like a sandpaper process. So you move those two surfaces against each other and they both wear out over time. Now, as you start to get bone surfaces involved, so underlying the cartilage, the bone, once that starts to get involved, you'll have other effects that have to do with bone recognizing that something's happening. So that may be the overgrowth of bone spurs that we see. So the body is meant to make bone anytime the periosteum, that nice thin layer overlying each bone that provides its vascular supply to the outside, anytime that is violated, the body knows that that's the signal to make more bone. So if we get to the point where the periosteum is disrupted around the joint capsule, the body will make bone spurs in defense of that. So that's one of our processes within osteoarthritis. Okay, so we have cartilage loss. We talked about that. Joint space narrowing. So in like a weight-bearing radiograph of the knee, the space that we can't see is actually the cartilage touching each other, but it doesn't show up on that radiograph. So when we get to advanced arthritis where the cartilage is wearing away, then that invisible spacer between those two bones starts to wear down, and we'll start to get to the point where we get to true bone-on-bone arthritis. Takes a long time to get there. Most people who tell me they have it don't actually have it. They have some cartilage surface left. So that would be our major findings, and we'll come back to those in a minute. Yes, Scott, bone spurs and osteophytes are synonymous. So our clinical symptoms for patients with osteoarthritis are first going to be stiffness. So in terms of me trying to differentiate like phrases or characteristics of a patient that would be different between these different types of arthritis, this is going to be kind of one of them. They're all going to say that they have joint pain. Most of them are going to have deformity, but these folks are going to have stiffness that is going to continue to increase over a period. Common locations for osteoarthritis are going to be any location that we use regularly. So the weight bearing, hips, knees, and spine are pretty common. And then especially for dexterous people, it sounds a little weird coming out, but people who have a lot of dexterity in their job, they will get hand arthritis as well. So those are some pretty common places that we'll see osteoarthritis. And then just remember that this is progressive. It's synonymous with aging. There is nothing I can do that completely arrests osteoarthritis. It's going to keep going no matter what I do. My main function in these patients is to help them stay active and have fun living life. Otherwise, you might as well just stop. And that's sad. So we got to help them, keep them moving, enjoying life. And that's where our treatment is aimed. So when we do our physical exam and we do our range of motion, kind of like you guys are working on with, well, you haven't started yet. Never mind. You just had the introduction. As soon as you start your PE2, you're going to start practicing your range of motion tests. And so when you do your range of motion tests on these osteoarthritis patients, you're going to find that it's gradually decreasing over time. Additionally, you may, so things that cause that, bone spurs, so they may physically block the ability of that joint to move because they've overgrown and they're getting in the way. Or cartilage fragments may be another one. So if that surface in between kind of breaks off like a little iceberg and is inside that joint, it goes and it eats friendly neighborhood cartilage for breakfast and tears up additional surfaces, which may cause mechanical blocks. Lesser blocks we call crepitus. I'm pretty sure that each of us has had a moment of crepitus in our life where we're like, oh gosh, I'm getting old. But it's that kind of cracking, popping, grinding, grossness that we have when moving a joint on occasion. Let me pause and read Jacob's question. Yeah, that is a great question, Jacob. So I have fun with patient education on this very topic. So this is I'm going to say that osteoarthritis is bimodal distribution. I'm totally kidding. So there is a level of perfect activity. And when you find it, please let me know so I can pass it on to my patients. But there's a level of inactivity where you get fat and heavy and additional weight causes problems that cause osteoarthritis. And then there's the other side of that where you're an ultra marathoner and a seamstress of elaborate costumes and you're abusing your joints. So we're trying to avoid those two extremes and sticking it in the middle. Yes, Army. Yeah. Army might fall on the ultra marathoner abuse side. So we want to stay that perfect level of active where we're getting the wheels greased and we're keeping the things moving smoothly and your muscles are strong and balanced, and then we'll avoid the bad things at either end. And no, and it varies from person to person. So that's why I say I love talking to patients about this, because they're like, sure, you don't know what you're talking about. But yes, exercise a bunch, but if you do too much, you can expect to advance your osteoarthritis. Precisely. Well caught, because it's not easy to counsel your patients on that one. They need to be active, but they don't need to be crazy. Okay, let's talk about some common things that we'll see with our osteoarthritis. In the hand, the distal interphalangeal joint, or DIP, will get Heberdean nodules. And we'll talk about these when we get to the hand and block too. These are kind of just ways for you to know that we have an osteoarthritis process going on. PIP joint, proximal interphalangeal joint, those are Bouchard nodules. They are very similar in construct, but there are some differences. One's more of a bone spur, one's a little more closer to a cyst. It's a lot of overlap and dissension in the ranks, but there are nodules that you'll find around those joints that get different names. And then the most common place is at the thumb carpal metacarpal joint in terms of hand arthritis. And that's the one that moves your hand around in a circle. So that where at the base of your thumb is one of our very common sites for hand osteoarthritis. In the foot, there are similarly a couple very common spots. The first metatarsal phalangeal joint is a common spot. That has its own name. It's called hallux rigidus, or a rigid first toe. And then between the tarsals back in the back of the foot, tibia and the talus is a less common place, but between the talus and the calcaneus, and then those two bones and everything in the distal rows is more common. The knee, very common, especially in our population due to the crazy things they do with their legs. Genu varum is a very common deformity that will result from just regular knee abuse. And that has to do with the fact that we bear our weight mostly through the middle of our knees, the medial compartment. Towards the inside. And once you wear that down enough and you sand off that surface, the spacer is decreased on the inside, whereas it's not decreased on the outside. And so they'll get a varus deformity or bow-leggedness. Medial compartment wear, we talked about that. And then with the hip osteoarthritis causes a very common walking gait. You may notice walking around the grocery store. If you didn't before, you will now. So they walk in external rotation. And if you were to do a physical exam on them, they couldn't internally rotate. They're actually stuck that way. So they'll lose internal rotation as part of the arthritis process. Okay, with imaging, I kind of talked through all of these when I was talking through the basic pathology. So again, here's our weight-bearing knee that's normal, and we have in between each of these bones, between the femur and the tibia, what is creating this black space is the cartilage. And we can't see it because it's not radio opaque, but that is what's causing this space. And then when we get into our osteoarthritis knee, we have that same space out here laterally, but that spacer has been worn away in the medial compartment. So we have joint space narrowing. We've got these little bone spurs sticking out. Here, let me zoom in. I think I can do, I'll just switch it over to my hand motion. Okay, so we've got bone spurs out on the outside. Kind of there. A little tough to see in this projection. I hope it's a little clearer for you guys. So bone spur formation. Sclerosis, when that comes up, is going to be an extra whitening of the bone just deep to that cartilage. So you may be able to see a little bit. This is a bad tibial projection, but maybe appreciate how this arc of the femur is more white than this arc of the femur, or that sclerosis. And then occasionally you'll get some subchondral cysts as well, which is just would be a white circle. Or sorry, the circle is black within the bone just deep to the cartilage. sclerosis, subchondral cysts, osteophytes, or bone spurs. So imaging, advanced imaging may be appropriate depending on the patient's age. I do not MRI every patient I think has osteoarthritis. It's useless unless they are a young person who has more advanced osteoarthritis than I would expect for them to have. A good case for this, and I just realized I hadn't talked about it yet, special. So there are two separate types of osteoarthritis. If we kind of go back to the definitions, primary osteoarthritis, which is that osteoarthritis related to aging, just normal, I'm getting old. And then there's secondary osteoarthritis. Secondary osteoarthritis has some kind of traumatic component. So if you break your wrist, and that changes what the cartilage looks like, and you're aggravating that sanding process, then that joint is subject to secondary osteoarthritis. So in terms of imaging for MRIs, I would use that more in a secondary osteoarthritis picture. And here's an MRI of a hip joint, and we're looking at this white flash that has the measuring tape on it. Let me do the zoom in thing again. So the white flash between the two measuring pieces, it's evidently 9.4 millimeters. Thank goodness for that. And we're looking at that cartilage surface, which is the gray line here. This white arrow is indicating what is probably a comorbid labral tear, and we'll talk about those when we get to block 3. But here on the far right is kind of what this would look like in arthroscopy. So if I went in and I looked at that surface, what would I see? So around the outside, the pearly white surface, that is the cartilage of this patient's joint. I can't tell you which one it is. I'm not that cool. I assume because it's attached to this hip picture that that's that patient's hip, but I'm not going to commit to that because there's no way for me to tell. This part in here is a window looking deep into the bone. So this is actually the bone surface underneath that cartilage. And kind of this white stuff is where it's starting to soften even there. So this would be a huge cartilage defect, probably 9.3 millimeters, being huge, like how I threw that term out, that would reflect that wearing away of the cartilage. Yes, it does pierce things, but not things that we care about. So we have where we call the portal locations. So places that we can kind of go through the layers of the skin and muscle and tendons and joint without doing exceptional damage. So approaches, and we seal those coming back out. Yep, something like that. It's much better with the knee than it would be in a hip like this. So what do we do about osteoarthritis? Remember, this is all about keeping them having fun and living life. So first things, we should probably avoid those extremes like the crazy ultramarathoners. And I don't have a thing against ultramarathoners. I have dear friends who are great ultramarathoners. It's abusive to your joints. So if it hurts, don't do it. You know, that kind of mentality. There's an orthopedic version, which is you're not really advancing this process too much. So if you can tolerate the pain, you might, and you enjoy the activity, you can keep doing it. Because I'm never going to tell you to stop doing something you love if you can tolerate the pain. But if you can't tolerate the pain, you should probably stop. We can help moderate that with some physical therapy. So if they have tapered off all of their activities so that they're not doing anything, well, they can't just go back to a full exercise regimen. So we may need physical therapy to help with strengthening, balance, confidence, activities of daily living, to really get them back and using that limb appropriately before they start like a walking regimen or something like that. Oral anti-inflammatories, we talked about that. We can use topical anti-inflammatories if they have heart or stomach problems. And then we also use a bunch of joint injections. And so I'm going to talk when we get back from break about there's a couple different things that we can do in terms of joint injections. we usually say 4 different types. And so when we come back, I'll start with the 4 different types of joint injections. I will see you back here at 6 after the hour. That is 16:06. Welcome back from break, everybody. Let's go ahead and talk about those 4 different joint injections. So 4 different things that we can stick into the knee to help change kind of what's going on within that joint capsule. So first thing would be an injectable steroid or corticosteroid. Purpose there is to decrease the inflammation that's going on within that joint capsule. We usually mix it with a lidocaine or a marcaine to numb the discomfort of me stabbing a needle into somebody's knee. So we'll do a corticosteroid, a short-acting numbing medication, and a long-acting numbing medication. And that's a pretty common mix that we'll have, and you'll learn more about that in phase 2. Second thing that we can stick into a joint is a hyaluronic acid derivative. So these include some brand names like Monovisc, Synvisc, Euflexa. They used to be made out of rooster combs. They're not. Now they're synthetic. But those act as basically a nutrient source for the chondrocytes. So they make joint fluid. So kind of gives them the building blocks rather than having to sort through your blood to find those building blocks to make the joint fluid. Third thing is going to be protein-rich plasma, or PRP. I'll come back to that, folks, just a second. So PRP is basically the pretty yellow layer out of centrifuged blood. Contains a lot of chemical communicators, the liquids, some white blood cell derivatives, and some things like that. We take that yellow layer off of spun down blood, and we stick that back into the patient after they donate their blood to the cause. The purpose there is to cause the body to have an inflammatory reaction. So it's the exact opposite of some other things, namely the steroid, or here in a second I'll talk about injectable NSAIDs. And that is supposed to cause a reaction so that the body has to do something about it. So with that comes, I can't let the patients take an anti-inflammatory like a naproxen or ibuprofen, naproxen, Celebrex. None of those for about 48 hours after they have a PRP, or protein-rich plasma injection. Last thing that I can shove into a joint is an anti-inflammatory. So we have just started some of the research on what that does to the cartilage surfaces. Kind of cool stuff. Worked on a project during residency that looked at Toradol injections into joints to see kind of what the pain change, inflammatory change was there. So those are generally the 4 things that I can shove into a joint. So a steroid, hyaluronic acid, protein-rich plasma, or an injectable NSAID. Ketorolac, correct. So folks asked, only give so many steroid injections. That is true. So like I said, 3 is what I want you to consider for the life of the joint. As soon as you get through that second one, you need to get them to ortho to see if there's other options like the hyaluronic acid. You can totally do those in primary care land if you have the resources, time, and the injectable. The ultimate thing is, the only thing that we can do that will definitively solve this problem, because it is a progression, is to do a joint replacement or arthroplasty. And then we take out the parts of the bone that are degrading and we replace them with metal components and plastic spacers. So nice knee replacement here on the right, kind of showing those shiny metal parts. Here's more metal in the tibial portion, and then that polyethylene spacer. Same here with the hip, with the acetabular cup, a stem that goes into the femur and replicates the femoral head, and a nice spacer there as well. So again, definitive treatment is going to be that arthroplasty. Okay, we'll move on to talking about rheumatoid arthritis next. So rheumatoid arthritis is an excess of the synovium, or the outside layers, the fleshy parts of the joint capsule. And this will cause very typical erosions right where the bone is, these excess tissue is pinched between the outside of the joint capsule and the bone. So right at where the joint capsule meets the bone, they'll have a pretty typical erosion pattern. Some typical places for a patient to have rheumatoid arthritis: hands and wrist, unfortunately, knees, feet, and ankles are all additional places where they may get a rheumatoid arthritis. But most of the people we know have hand problems. So what symptoms would a patient with rheumatoid arthritis present with? So the pretty typical one that everyone loves to include in their test questions is morning stiffness that lasts more than an hour. So if they have trouble warming up their hands, that may be something the words they use, warming up their hands, that may be an indication of rheumatoid arthritis. Swelling, and we'll talk a little bit more on the next slide about kind of what that swelling means, because it's not typical extra fluid in the capsule. This is other problems. And these folks are going to have other systemic symptoms. So they may have pain in their hands, but they're going to have something else going on elsewhere because, again, it's a systemic disease, changing all the joints simultaneously. They just may have worse symptoms in their hands. It's a similar pathology, Anders. When you get to talking about things like lupus, you're going to talk about those in rheumatology as a senior. This is about as far as we get into autoimmune disorders. But they have similar pathologies. So a couple things that we really worry about with rheumatoid arthritis is C1-2 instability because of the odontoid ligament rupture. So remember I talked about ligament and tendon rupture kind of in the introduction section. So this wearing of those odontoid ligaments can be a serious problem, especially for general anesthesia. So when you find out about the patient having rheumatoid arthritis is not when you have an internal decapitation because you tried to administer general anesthesia. So we want to know about things like rheumatoid arthritis when we do general anesthesia procedures because of this risk of ligament rupture. Tendon rupture, I talked about that, has to do with changes to how elastic or resilient those tendon and ligament fibers are from the disease process. And then because of uneven wear and changes, they will have deformities at a lot of different joints. And we'll talk about those when we get to imaging. So first thing that we're going to find on physical exam is synovial hypertrophy. Again, that's an excess of the inside surface of the joint capsule, the synovial capsule. So there's more of it than there should be. So it's basically got wrinkles. So I tried to kind of show that here in this arthroscopy picture. So these are all those extra surfaces of synovium here within this particular joint. I suspect it's probably a knee, but I'm not committing to that because I can't tell. So yes, I personally think it's very pretty to see excess synovium, but it's not nice for the patient. It waves in the arthroscopy fluid, kind of like seaweed, and I just find it very pretty, but not pretty for the patient. Now, this causes a boggy joint, which could be inferred as swelling. So if you touched this, when you look at it, you may say, ooh, that joint is swollen because it's bigger than it should be. But if I touch it, it's not like poking a balloon. It's like poking one of those sand-filled balloons. You guys think of what I'm trying to convey there. It doesn't poke one side and it squishes out the other. It kind of feels different there. So it's not a true effusion, but it is boggy joint is the word for that. Oh goodness. Charter's walking me into movie references. I'm gonna say Charter. Correct. Excess capsule. Kylie. I'm gonna go with that because that sounds great. If I mispronounce it, you should tell me now. Okay. It's never going to happen again. So we can go in and we can take out that excess tissue with our tools through arthroscopy and leaving you more with what this is, which is a little more normal. We normally don't have all these little hairies sticking out. Okay. And then we may also note a deformity. So this particular patient has ulnar deviation of her fingers, or her fingers are splayed off in to the ulnar side of her hand. And that's a pretty typical deformity for rheumatoid arthritis. Fun x-rays that don't show up for 2000. Let me answer Jacob's question before I move on. No, Jacobs, we can go in and we can, assuming the joint is large enough that we can get into it with a scope, then we can take out the excess synovium. That's why I think that previous picture was probably in knee, is because that is a joint that we can get into with the scope. So we can get into the wrist is probably the smallest joint we can get into with the scope. So big joints. So hands, finger joints, we're not going to do much there. Okay, so things that we notice on a rheumatoid arthritis x-ray. So the first thing is they should have disuse osteopenia. So their bones should not be as white as they may be in other places. I feel like I have to sneeze, so if I do sneeze, just please excuse me. Okay. Bony erosions, remember that's where that excess tissue is getting smashed between the joint capsule and the bone, causing extra sandpaper to go there. And then we may see some of those deformities as the process advances. Hopefully between either the PDF or the PowerPoint, you guys got this picture, but it kind of has that same comparison showing you a normal hand on the left and a rheumatoid hand with the erosions and the joint space narrowing on the right there. Some laboratory findings that we may find with rheumatoid arthritis, rheumatoid factor. And if you guys will remember from Clin Lab, that was just a thing that they found. The one that is more specific for rheumatoid is actually that anti-citrulline citric peptide, anti-CCP. There's a reason we have big words that turn into little words. So those two labs are more specific for our rheumatoid pathologies. So what do we do about it? So our big thing with the rheumatoid arthritis is to manage those symptoms systemically, because it is a systemic disease. The changes in the synovium and bones are occurring in every single joint. We just find it some places faster. So we want to control it systemically. So that's the disease modulating anti-rheumatic drugs named after the disease that we're trying to treat here. And those are all synthetic medications that we use to moderate the autoimmune disorders. We can also do some of the anti-inflammatories, injectable anti-inflammatories, to decrease the irritation within that joint capsule to kind of keep it calm. But the same thing applies to this joint as it does to the others. So we can't use them all the time because of all of the risks of the corticosteroids. Yes. I assume Horspool is referring to the disease modulating anti-rheumatic drugs. So that's our first line medication, controlling it systemically. Injectable steroids we can use to calm the irritation within that joint capsule, but we still have that same rule about the 3. So we can only do it in extreme situations. Did that cover the question? Okay. And then we can still use operative interventions in a very similar manner. So we can go in and do an arthroplasty or a joint replacement if the joint erosion is severe. Or if we are suffering from some kind of tendon rupture, we can go in and do some tendon transfers to help with that as well. And then, as we kind of talked about with the pretty picture with the excess synovium, we can maybe do some cleanup if it's in a large enough joint. Anders, that depends on which the least functional is. So it depends on each part of the body, definitely outside of the scope of this course, but I'd love to talk to you about it. But we take the redundant, basically we find redundant tendons and we take whichever one is most redundant, least functional, and we put it someplace else and then retrain it. Sure, I'll go with that, Jacobs. The hands actually have more than we need, so we can move some things around to help even things out. We try to take it from the same compartment, like extensor compartment or flexor compartment. Otherwise, when you fire it, it does weird things. Yeah, cadavers do, but because it's already an autoimmune disease, they may wear through that exceptionally fast. So we'd have to take their system down to something that probably isn't functional to fighting disease. Super fun. Yep. Okay, seronegative spondyloarthropathies are our next topic of discussion. So the text goes into 4 general groupings of this. So the first is ankylosing spondylitis. So we'll talk about that here. And then again, when we get to spine. Reactive arthritis or Reiter's syndrome. You guys probably have a catchy mnemonic, so I'll let you guys throw the next mnemonic out. Get set, go. For your reactive arthritis, Reiter's syndrome. Psoriatic arthritis and arthritis with irritable bowel syndrome. Nobody wants to dive on that hand grenade. Can't see, can't pee, can't climb a tree. I'm sure you guys have other ones, but that's the one that I'm sticking with. Yeah, see, but there are other ones that are less clean than the one I just picked. Okay. So the things that each of these have in common in terms of clinical pathology is that they all start at the sacroiliac joint and ascend. So they start here at the SI joint and they will ascend through the spine. So they'll have low back pain, but there should be sacroiliac involvement as well. So kind of got to pair those things together for this particular pathology. So what additional things can we find on physical exam? So enthesitis is where tendon meets bone. So it's kind of a weird version of tendinopathy, but that is something common among all of the seronegative spondyloarthropathies that goes outside of the back specifically. And then depending on which it is, they might have a comorbid condition. So Reiter's syndrome, we typically associate with STIs. The irritable bowel disease arthritis, they should have irritable bowel disease. Psoriatic arthritis, they should have psoriasis. So some things like that would cue us into which arthropathies they go. Back 2 slides, says Jacobs. Yeah, yours does look a little bit different. I'll hold here for just a second because yes, when I was going through them prepping for lecture, I was like, that's not even a complete thought. There's like a 2-3. I promise it's limited to, this was the one where I had to make something because it was different. Okay, Jacobs, was that enough time to scribble? Two people are typing, so I'll wait. Okay. Back. Okay. So some cool imaging things, pretty typical that we like to throw out on these. So it's where the tendon meets the bone. Irritation. And that's in an adult, not in a kid. If it's in a kid, it's something different. We're not going to talk about that for like 2 more blocks. Okay, cool things about a couple of these. So in terms of imaging, every test I've ever seen has some question about ankylosing spondylitis because it's pretty typical. So when I learned it, I learned a bamboo spine. This text likes the phrase poker spine. And these have preserved disc spaces. So let me zoom in on our pictures over here. So what this is referring to is ossification here and here. So you can see how each of these spaces has been bridged by bone spurs that connect the upper vertebral body to the lower vertebral body, kind of giving you this picture that looks like bamboo, where this is the vertebral body and that's the joint space. But it's important to note that the disc space on these are pretty preserved. So the height here is fixed, and that's because it's stuck that way. All the way around in 360 degrees, that's bone all the way around the outside of the disc. So it's stuck. So it won't get degenerative disc disease. So maybe that's what it's protective for. I don't know. But they will have preserved disc spaces. And then we can kind of see that this is a little bit harder, I think, from your point of view in terms of finding that same ossification out on the lateral sides. But it is still there. So bridging between the upper vertebral body and the lower vertebral body goes all the way around. Again, bamboo spine. And this text likes that, says poker spine, in case you're wondering what that means. And we'll find another pathology when we get to spine that will use this preserved disc space. Now, laboratory-wise, the thing that makes this seronegative up here at the top in the definite, like what we're talking about, seronegative spondyloarthropathies, that means that the serum is negative. So the begging question is, well, what is negative? That's rheumatoid factor. So these were separated out because they are rheumatoid factor negative. So just that's why they're called what they're called. And then the rest is back arthritis. So seronegative, having to do with a negative RF and anti-CCP. But in their overzealous nature to find the labs that were positive in these folks, they did find that these folks with the seronegative spondyloarthropathies have that HLA-B27 you guys learned about in PATH. It should be negative also. I was wondering that as I read it too, Morgan. I'm going to write that down and answer that question when we start. I know the yellow is highlighted because that's where it gets its name, but I will verify lest that be confusing. And I'll throw in another negative for next class. Okay. It would have both. I try not to single out any one thing that you would never test for by itself. Like I'm never going to just test for anti-CCP. I'd always get the rheumatoid too. And if I'm running labs, I'm getting HLA-B27 too. So you would have this be positive and that be negative. So that should get you there, right? Cross my fingers. Okay, so what do we do about it? For most of these, you've got to treat the systemic disease that's causing the arthritis. So if it's arthritis with inflammatory bowel disease, treat the inflammatory bowel disease. Autoimmune disorder, you treat it kind of as you learned gastro last term. I'm going to stay out of that. That's not my realm. But you'll treat that disease. Psoriatic, same thing. Treat the psoriasis. Reactive arthritis, Reiter syndrome, treat that infection. That helps decrease the irritated properties that are circulating around in their system helps their arthritis go down. Worst case scenario, again, we can go through and we can take out that joint if it's in a knee or a wrist or one of the joints we can take out. There are spine arthroplasties too now. They're just not as common. For the most part, these get complex and may be out of your primary care comfort zone pretty quickly, pardon me. So these are going to end up in different referral centers based on their symptoms. So like, I don't do psoriasis, not going to help. So that might be that derm we were talking about earlier. Irritable bowel, not my realm, don't do bowels. So that might need to go to gastroenterology. So depending on what is the root cause of that arthropathy, that will be the where you're sending the patient. Some of them will end up in ortho because they have ortho problems, joint and bone things, and those come to us. So we can do things to joints, stab them, take them out. Okay, compartment syndrome. Ooh, something fun. Systemic disease does not excite me. So compartment syndrome. So when we talk about compartment syndrome, we're talking about increased pressure within the bounds of a compartment. Seems pretty reasonable. So what is a compartment? So that is a thick fascial layer that surrounds a section of muscle. So pretty typical one is here in the leg. It's probably the one you guys did in pathology. So there are 4 leg compartments that have different muscles and different nerves in each of them, vessels. And around each of them is a thick fascial layer. It's surgically, it's about like tissue paper, but unfortunately in a human being, it does not react like tissue paper because in your mind, tissue paper, you just put it under stress and it disintegrates. This almost gets tough, very restrictive in terms of what can flow through that area. The pericardium sounds like a great equivalent. So the pericardium, you can grab and feel it around the heart. So this is just a different muscle that we're talking about, but same general principle. And then something happens within the compartment that means that it's swollen and it's pushing outward onto that layer, but that layer is not giving. And as the pressure increases, structures that are compressible, like your vessels and your nerves, those start to be compressed. And as we know, nerves that are compressed and vessels that are compressed do not appreciate that. They cry out in pain, and then your patient cries out in pain. Acute compartment syndrome is caused by trauma. So fracture of the tibia is the most common cause of acute leg compartment syndrome. Forearm fracture, both bone forearm fracture is the most common cause of forearm compartment pressures. Same thing with the thigh compartments, femur fracture. Chronic is something less so. So this may mean that the compartment is shrinking, becoming more fibrous and tough. And then they try and do something like a new activity, going for a run when they haven't for quite some time. And there's just no more room for that muscle to react and get that extra blood flow that it needs to be able to be a muscle. So this can change over time, going both directions. Yes, chronic, I agree there, Fuchs, absolutely. So what would bring them in to complain to us? So historically, the 6 things that we remember for this are the 6 P's. Pain, pallor, paresthesias, paresis, poikilothermia. That means cool because you'll remember from cell language that means little therma. So cool. And then pulselessness. Now I have signaled to you which ones that I care about the most. Pain. Pain, 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 pain. If there were 6 P's that were all pain, that would be compartment syndrome. paresis, or it doesn't work right, like a foot, and pulselessness are such late findings that if that is your primary finding, your patient's limb is screwed. So I don't want those to be the things you're looking for or waiting for to say this is compartment syndrome. If you have waited until they have paresis and pulselessness, your patient's limb is nigh dead, and that is bad. So pain, 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 out of proportion. Sure, it should be pain out of proportion. But as these people have leg fractures or arm fractures, that's really hard to like. Phase one, I can differentiate these things. So pain, it's hard. It will be out of proportion. Some ways that I would test on that, you give them appropriate pain medications and they're still at that, like, how does Leftwich say it? Extreme levels, severe levels of pain. Isn't that what your scale says? 9s and 10s. So if you give them morphine and they're still at 9 and 10, something's wrong. Okay, so your 6 Ps, pain matters. Don't wait for paresis and pulselessness. That's bad. So what's going on in terms of pathophysiology? Necrosis of that muscle within that compartment or nerve damage. So depending on whether we're changing the blood supply on that first bullet or the nerve on that second one. Yes, so we can add pressure to that, and we'll talk about that. So I accept that as the 7th. The text doesn't use that one. I learned that one in residency charter. So charter's just saying that we now consider there to be a 7th one, and that's your pressures. And we'll talk about what that means on the next 2 slides. Okay, so depending on whether we're cutting off the blood supply or the nerve kind of leads to these 2 adverse outcomes. So our first physical exam thing is, again, related to pain, and that's going to be passive stretch or elongation of that compartment. So muscles within that compartment. So here's a passive stretch. Well, this appears to be pretty active as there's a human being manipulating this. But stretching, sorry, it is passive. I'm having a blonde day. Wow. Passive stretch, person manipulating it, of those compartments. So they've flexed that wrist down and extend the wrist up. And so they're stretching one of the compartments. So stretching up on that top and then down on the bottom in this one. And that stretch or elongation of the compartment further decreases the circumference. That increases the pressure. Again, there's a whole bunch of physics laws in there. I'm going to stop now before I get out of my depth. So passive stretch of the muscles within that compartment. You might say, well, why don't I just get them to do it and increase the muscle diameter, which would be active motion. You would increase the muscle diameter. They're probably not going to do it because they hurt really bad. So we have to do something for them to measure that. If you can get them to move it, then more power to you. Better exam. So some diagnostic tests come with this, which is where Charter was going, and that has to do with the pressure within the compartment. For acute compartment syndrome, there is a relationship in the text that's provided that says that it's in relation to their diastolic pressure, and basically means that if the compartment pressure is higher than their blood pressure, you can't get blood into that compartment or out. So it's all related to that. I have never strikered, which is the tool you use to measure the pressure in acute compartment syndrome. It doesn't matter. I am not going to say, I wonder if this is compartment syndrome. I should pull out my striker and stab them a whole bunch of times to determine if their pain really is out of proportion. I don't care. If I think this is what's going on, they're getting the surgery to treat it, regardless of what the compartment pressure says. So I kind of say that so that you understand the principles behind why we would care about the pressure within the compartment. but the math does not make much sense, so I don't focus on that in terms of testing. Where I will is with chronic compartment pressures, and this is the most unkind thing I've ever done to any human being ever. So with chronic compartment syndrome, you test their pressures at baseline after exercising so they exercise till they have pain, and then they stop, and 1 minute later we stab them, and then at 5 minutes later we stab them. Now, when we do that, that's what this picture down here is. Oh, silly me, that's my pen, not my hand. So see all these places that this person is getting stabbed? That's each of their compartments. We have to measure each of their compartments, and usually in multiple places. So they end up getting stabbed a whole bunch of times. That's why it's not nice. For the most part, I've only done this to a human being once, and they were so mad at me, I don't do it much anymore. Sports medicine, though, will, if you get them there. So they put them on a treadmill and then stab them a whole bunch of times, and that will confirm the chronic compartment syndrome. I'm with you on that, Jacobs, especially since the treatment. So in the military, they get out. You just don't run anymore. We can gait retrain now, which I'll talk about in a minute, but there are options aside from being stabbed 1,000 times. Okay, in terms of definitions. So if their compartment pressure at rest before they've done anything is more than 15 millimeters of mercury, that's diagnostic. Same thing with greater than 30 millimeters of mercury 1 minute after testing, and 20 millimeters of mercury 5 minutes after testing. So these are testable principles, because you'll see that in clinic. Okay, so what do we do about it? So the text does not go into anything that you can do about chronic compartment syndrome. It just basically says, don't do that thing. Well, that's great, but what if your compartment syndrome goes off after walking for 100 yards? Well, that person is doing nothing in life. They can't even go to the grocery store. So we might need to do something else to deal with that. So gait retraining is something that applies to both walking and running. It looks very much akin to prancing. So they load off of the toe instead of loading off of the heel. And that changes which muscles are dominant, the big muscles in the back versus more anterior muscles. Let me pause. So Earwood, I think kind of where I would go with that diagnostic thing is for your practice, that's going to have to do with separating them from the military. But yes, the whole test is you have to do it all of the times. So you still have to make them get on the treadmill and make them have pain. And hence the I don't like it. Okay, so chronic, we do have options. Gait retraining is one of them. Acute compartment syndrome is emergent. So we go in and do a fasciotomy. And what a fasciotomy means is that restrictive layer that's around the muscle, we unzip it. We cut it down the length. That's why this guy has been unzipped from knee until his ankle. And we cut that open, and then it can swell however much it wants. It's not going to cut off any blood supply, and this is a terribly bloody procedure. I'm going to come to that in a second. The adverse outcomes of this is a giant scar. So, I mean, this person, look at this scar that they have for this forearm fasciotomy. It's giant, and like in a chronic, you can do a fasciotomy, but the risk, this is limb saving if it's acute. If it's chronic and they get like some kind of wound complication, then that's a huge problem. And that's what I've seen. So my N of 3, 2 of them had horrible wound complications that were more troublesome than their original complaint. Okay, let me get caught up on so Scott, that goes back to fascia grows back. So it will come back together and it will heal. And then they'll just get the same thing over again. And if you can tell me a story about somebody who successfully learned to run again after a fasciotomy, I have an N of 1 on that one too. And it happens, absolutely, Scott. I agree. It just not something that happens a lot in the military, probably for secondary gain reasons. And then Schmidt is asking, exercise until pain is felt, drop pressures afterwards. Yes. I actually like the success stories. I sound a little pessimistic, but Scold has a sister who had both done. So the good thing is if you find this, they all end up with us. So it's not me who decides, it's the surgeon. So the one thing I do want to share, hold on, I think that we're going to stop there. So the one thing I do want to talk you through with this is a battlefield procedure. So if you have someone who is on the battlefield and has acute compartment syndrome, this is a truly emergent procedure. It is limb saving. So this is done on the battlefield. As I said, it's horribly bloody. But you basically dissect down under the skin, you poke at the fascia and say, yeah, that's tight. And you just do a very thin cut down that entire fascia. And your pulse is in your ears. And it's, yes, roll one, even further forward than that. You can. This is not a medic thing. Don't hit a big blood vessel. I have a story, but I'll share it when we get to leg because it's more fun with leg. Yes, and this is definitely limb. Yes, Hermic. Sorry, that was definitely prolonged field care. I'm going to stop there. We will pick up on complex regional pain syndrome, which I believe is our last topic. Yep, we'll pick that up tomorrow. So I'll stick around until 5 for any of your questions. You can share your GORT. I want to hear your stories about your chronic exertional compartment syndrome. I'd love to see their current pictures because for me, it's all about wound complication. But I'll stick around. Otherwise, I'll see you tomorrow at 1300. Bye, guys.